And thank you for remembering to ask that.
All
All right, well, I'm going to turn it over to you, Mary, and you can introduce yourself. And then as you hand the baton to Christine, if you can share her information, and we'll go from there.
Sure. Great. Thanks again for asking us to come back. It's always fun to speak to this group. And I'm as Diane said, I'm the nurse manager for Mayo, Northwest Wisconsin's Hospice and Palliative Care program. And I've been at Mayo for 30 years and spent about 20 of those or 15 of those in the ICU setting. And then I've been working in palliative care for about 15. So this is an area that's near and dear to my heart. And Christine is one of the nurses in our palliative care program now. And she also, she can introduce herself too later, but also has a long history as a hospice nurse as well. So Christine, if you want to go ahead and share the PowerPoint, that'd be great. All right. So Christine, can you go up to the top where it says slideshow? Just under the orange, there you go. Just over to the right a little bit further. Yep. And click on that. And then click on from the beginning. Way to the left. Thank you. Thank you. All right. And then if you click on display settings up at the top, click on swap presenter view. Thank you. Perfect. Okay. And then for advancing, Christine, there's arrows down in the lower left-hand corner that kind of are faded. So we are here to talk about palliative care and how that relates to people who are experiencing ALS. We can go to the next slide. Maybe. So Christine and I, this is our first time as a duo. So there we go. So just wanted to start out just with an overview of what palliative care is. And this is an article that was in the paper quite a long time ago now, probably a decade ago. But so often when we talk with people about palliative care, they think that we're there only to talk about death and dying. And really palliative care and hospice as well really focuses on life and how do we help people make the days that they have as meaningful and full and comfortable as possible and really focus on what's important to them. So you can go to the next slide, Christine. So what do we in palliative care? And I should say there's over the last decade, palliative care is now a medical specialty. So there are palliative care teams like us, like Christine and I are on, that palliative care is what we do all day long, every day. And that's called specialty palliative care. But other healthcare providers like primary care doctors, neurologists, oncologists, cardiologists might be providing some basic palliative care as well that focuses on symptom management and goals of care and things like that. But mainly we'll be talking about specialty palliative care today. So our goals when we meet a patient and their family is to really understand the big picture for that person and their family and get to know them. We want to know kind of what your life has been about, what's been important to you over the course of your lifetime, what's brought you joy and meaning, what have been the struggles. And as we get to know you in that way, that helps us work together to create the best plan for your future medical care and decisions that you might need to make. We focus on quality of life and prevention of suffering. And that focus on quality of life really is individual to every person, what that means. We have different views about what makes life meaningful and enjoyable. And that's why we want to get to know each person so closely. Another part of what we do is matching the treatments that are planned for each individual with what is important to them. So what are their goals? What are their preferences for care? And again, that's so individualized. It can be impacted by past experiences, by what they've seen other people go through, by sometimes religious beliefs, by social values that they hold. So again, it's all about building a relationship with an individual and their family or their caregivers, and getting to know them, and making sure that as they go forward, making plans for the future is based on informed decisions and patient-centered decisions. So we also help a lot with future planning. So that's another aspect. You can go to the next slide.
My little gray button's been away, Mary.
Uh-oh.
There we go.
Oh, there you go.
Oh, okay, we're good.
Yep, that's good. Thank you. We also want to emphasize what it's not. Many people, especially when we meet them in the hospital, think that we're there to talk about hospice, and we're not the same as hospice. Hospice is actually a subset of palliative care. So has the same goals, but it's really reserved for those folks who are in the last months of their life, as far as we can tell, and who have opted for truly a comfort-focused approach to their care, and are not really interested in a lot of hospitalizations or surgery or life-prolonging measures, but really want to focus on kind of making the most of the time and keeping symptoms well controlled. Palliative care, this is another misunderstanding sometimes, is that if someone is engaged with palliative care, it's an alternative to other active treatment for illness, and that is not the case. So palliative care can go right along with very aggressive treatments. And when people that we work with are pursuing aggressive treatment, the things that we think about are how are you handling the treatments? Are there side effects? Are there financial or social stressors that we can help with? Being a well-known team that kind of journeys through the healthcare experience with people, a place to bounce off questions and really get that psychosocial support and detailed information about options. So it's not the same as hospice, but we're cousins, and hospice is a subset of palliative care. You can go forward. I should have said, if there's any questions along the way, please feel free to interrupt, or put a question in the chat, and hopefully Diane would see that and can interrupt me and bring that up. So where do you get palliative care? Most hospitals now have a palliative care service. I don't know the most recent statistics, but I know in hospitals over 50 beds or 100 beds, it's been at least 75% of hospitals have palliative care teams. Some communities have home-based palliative care available. We do have a home-based palliative care team at Mayo here in Northwest Wisconsin. And different hospice and palliative care agencies around the region, a few of them provide it at home as well. Some clinics provide palliative care, just like any other specialty you would go to see. Our program at Mayo, we have just a little bit of clinic practice right now. We're hoping to grow that in the next year or so. And then we also do see people in nursing homes and rehab facilities. You can go to the next slide. A palliative care team might include all of these individuals. This picture is our team a couple years ago, where it's not quite up to date anymore, but the teams usually involve physicians, nurse practitioners, nurses, chaplains, social workers, and therapists. And the therapists might be physical therapy, OT, speech therapy, depending on what a person's needs are. And different places that, because palliative care is still a relatively new field, the teams look different at different organizations. So not all organizations have a dedicated chaplain, for example, or a dedicated nurse even. Some just have physicians and nurse practitioners. Some have just nurses and nurse practitioners and a social worker. So it's unique, but the goals are the same. And we do work closely with a patient's other care providers. So if someone is following closely with their primary care doctor or with another specialist. As we work with the patient, we want to work closely with that other team member so that we're not doing things that contradict or are confusing. We want to make sure that patients and families are getting consistent messages and consistent direction. Okay, you can go to the next slide. Sometimes people want to know who pays for this. So palliative care is treated just like any other specialty by Medicare and most insurances. So whether you're seen in the hospital, in the clinic, or in the community, it's treated just like a visit with a cardiologist or a gastrointestinal specialist or pulmonologist would be treated. So they are covered by Medicare and most insurances. All right, you can go to the next slide. So that's really a kind of an overview of general things about palliative care, what we focus on, what our purpose is, how we do that work. But we want to talk a little bit more specifically about in ALS, how can palliative care possibly be helpful? So you can go on to the next slide. So again, I talked about getting to know a patient and their family. That's really our first goal, is to get to know your story. We want to understand what you understand about your illness and where you are in its progression and what that journey has looked like for you. We know that people with ALS have very different courses sometimes. And so we want to know kind of where you're at and what you understand and what you're expecting. We want to hear how this is affecting you and how it's affecting your family, because those are some of the things that we can help with as well. And those things might be impacting some of your decision making. We want to hear from you as you think about the future. What are your biggest worries and what are your hopes? Because that too can help guide how we counsel and direct you and provide information about options you might have. And then what is most important to you as you live with this disease, and again, that's very, very individualized. So hopefully, if we're doing our job right, we're going to be listening a lot more than we talk, and we want to hear from you, first of all. We do provide information. So I can remember when I first started doing palliative care, I remember the first gentleman I worked with who had ALS, and he was at the point where he was using a wheelchair at that point, but otherwise was still quite functional and pretty independent. And we just talked about, what the future might look like. This gentleman had felt like he didn't get a lot of information from other teams that he was working with. And so we just talked about, what the course might look like, what to expect, what are some decisions that he might have to make at some point in his journey, whether it's months away or years away, and what those different treatment options might involve. Next slide. We also, one of our big focuses, because we want to prevent and relieve suffering, is looking after symptoms. So some of the symptoms, again, this is very unique to each individual, but some of the symptoms that people might experience with ALS is pain and stiffness, spasms of muscles, pressure sores, trouble with secretions, oral secretions, shortness of breath, psychosocial or spiritual distress, dealing with a serious illness like ALS, constipation, trouble with urination, fatigue, depression or anxiety, and difficulty with communication. And I'm guessing that some of you are well aware of some of these symptoms at least. You can go on to the next slide. We also assist with planning for the future. And some of those things might include ensuring that people, both the patient and their family members, because we believe that this is important for every adult to have a power of attorney for healthcare in place, so that if the time came that someone was not able to make decisions for themselves, they would have a trusted individual named who knows them and knows what's important to them to make decisions for them. We also, as I mentioned, planning for the future, talking about certain life-prolonging treatments that may be a decision in the future, and being able to talk about those things before you're at a crisis point or before you're at an urgent decision-making point. So you have some time to really think about it thoughtfully and talk with your family and loved ones, anybody that you trust and want input from before you have to make those decisions. And then another one that we always talk about is CPR or resuscitation and what people's wishes are related to that. And, you know, each of these we could talk for a whole hour about, so we're just barely touching on them, but we talk about CPR and, you know, in each person's individual situation, what would that look like and what would the potential outcome be? And what does that mean for each person and their wishes and goals and values? All right, next slide. So some of the treatment decisions that people who are experiencing ALS might have to make, again, it depends on the course that your disease is taking, but some of the decisions that come up are feeding tubes, particularly a PEG tube, BIPAP or non-invasive ventilation, tracheostomy and ventilator, and comfort care. So we're just going to walk through each of these briefly. So a PEG tube is a feeding tube that goes through the wall of the abdomen into the stomach, and it allows for either supplemental nutrition, meaning the person is still eating some, but not taking in enough to maintain their bodily needs, or it might replace nutrition by mouth completely, and provide all the calories and protein and things that a person needs. The benefit is it can really help keep your weight up. It can also help preserve energy if eating is taking a lot of time and energy and causing a person to be exhausted. Using feeding through a tube can allow you to preserve some of that energy for other activities that you want to be able to participate in. So again, that's an individual decision on what's kind of where you want to spend that energy budget. And a PEG tube can help with that. We know that for people with ALS, it's best if the PEG tube is placed when breathing is still going pretty well. Partly that's related to the procedure itself, and that getting that nutrition, taken care of, can really help provide that energy for breathing. Side effects are pretty minimal. Of course, because we have a puncture in the skin, we're breaking the body's natural barrier. There's always a slight chance of infection. So, that's something that is watched closely, the skin around that tube, but usually is quite easily managed. The tube can become blocked. So there's things that we can do as healthcare providers to help resolve that. The tube can come dislodged. Again, that's pretty unusual, but it's not a difficult thing to replace those tubes if it were to come dislodged. Okay, the next slide. BiPAP, or non-invasive positive pressure ventilation, is another thing that you may encounter or be presented as an option for you. And this is it's called non-invasive because it's not putting a breathing tube into the throat or the nose, but it's a mask on the outside that is fairly snug. I'm guessing maybe some of you have experienced it. Many people without ALS use this as well for sleep apnea. And it provides some pressure that makes breathing a little bit easier. It helps keep the airway open with that positive pressure as you take a breath, pushes air in. This can help sleep, which then can make your days better. Again, it helps increase energy if you're able to get better sleep. It can prolong survival, but it is a snug mask, and some people have difficulty with that, especially if they have any trouble with claustrophobia. Some people need it just part of the time. Some people need it all the time. So that's just another thing to think about. There are some new options, and I don't have a lot of experience with them, but we've just been talking about it on our palliative care team a little bit, where people don't use a mask, but it's more like little pillows that go into the nostrils. So I don't know if maybe some of you have seen that or been have tried that. It's just not quite as, doesn't cover the face quite so much. Right, next slide. So tracheostomy in a long-term ventilator is another option that is often a consideration for people with ALS. Sometimes the tracheostomy is needed just to help with clearing secretions. It doesn't necessarily mean there would be a ventilator attached to provide the breaths that a person needs. If their diaphragm's no longer strong enough to provide natural breathing. But the tracheostomy is a plastic tube that is inserted right into the trachea in the front of the throat. And if patient's cough isn't very strong, and they're not able to clear their secretions, that is a way that we can suction secretions out and help prevent some pneumonias and other complications of that. However, oftentimes a tracheostomy is also used to attach to a ventilator. And just like BIPAP, that can be something that people use only part of the time, like at night, or it could be 24/7, depending on the stage of the illness and if they've opted to use a ventilator. So the ventilator does prolong life, but it does increase the care requirements quite a bit. If someone is on a ventilator, they need 24/7 care in case that ventilator would need attention or the tubing would become disconnected or something like that. The ventilator does not do anything to reverse the disease, but definitely does prolong life. Some of the side effects, though, are that speaking while you're on the ventilator, you're not able to speak. There can be, again, because we've got something going in through the skin, a risk of infection around that tube. People can have pneumonias, just like without the ventilator. So those are some possibilities. And again, it's a very individualized decision. Christine, if you want to go on to the next slide. I am going to switch it over to Christine because I have to step away. And again, my apologies for that. This was an unexpected appointment that we needed to go to today. But Christine, this is kind of her area of comfort care. And so I will hand it off.
Can everybody hear me okay?
Yes, we
Yes.
can. And I just want to say thank you, Mary, for fitting this in, and we'll talk soon.
All right,
Thanks.
you're welcome. Thank you.
All right, so when we talk about comfort care, we're often using medications to help control shortness of breath, pain, anxiety. We do use medications like opioids and benzodiazepines to help ease some of those symptoms. We just have to do that really carefully so that we don't depress a person's respiration. Again, the oxygen or the BiPAP, if it's helpful, if it's desired, if it makes a person feel better, by all means, we want them to use it. We want to provide really excellent physical care. People towards the end of the ALS process are often fairly bedbound and are at high risk of pressure ulcers and skin problems. So they do require quite a bit of care. We want to provide emotional and spiritual care to the patient and their loved ones. So these decisions are all very individual. Some people would never want a ventilator. Some people would absolutely want a ventilator to live as long as they can. There's absolutely no right or wrong. That's why we want to start the conversations early and to make sure that they're really thoughtful. So again, like Mary said, if it comes to a crisis point, the patient and family really kind of already know what they would do. So just having those really good conversations early on is really important. Trying to get my slide to advance. There we go. So we like to have these conversations ongoing. We know as the disease process progresses that goals can change. So we just like to check in with our patients periodically. Are we still on the right track? Is this still making sense to you? Are we providing you the right care? And the decisions that are made that day Although they are well documented, so they can be followed, they're not written in stone. People can always change their mind, and maybe what made sense yesterday isn't going to make sense by tomorrow, and then we can pivot with them. Eventually, we do talk about transition to hospice care. So hospice care begins when the patient and family are ready and they're in line with the philosophy. They don't want to return to the hospital or clinic anymore. It can be at all avoided. And when we can, per anybody's best educated guess, determine that that patient probably has 6 months or fewer to live. And we know that we never know that for sure. And people can live longer sometimes on hospice and with the really good care that hospice provides. But hospice does focus on comfort, patient-specific goals. And again, both the patient and the family are the ones being cared for. Mary has a quote on here from Dame Cicely Saunders, who is kind of the founder of modern palliative care and hospice medicine. And it says, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." It's kind of a cool quote. So what does hospice provide? Hospice provides a whole interdisciplinary team that the patient and family can tap into kind of as much or as little as they want. And there's quite a bit of variability. Some people say, you know, I don't want a bunch of people coming through my house. And other people will say, yes, send them all. The more help I can get, the better. So that's just an ongoing conversation with the team. But patients always will have an RN case manager who might see the patient once or twice a week if things are going pretty well, or might see the patient every day if things are kind of bumpy and there's med changes and different changes that we're seeing and working with. There is a nurse on call 24/7. And I think that's great peace of mind for the patient and family to know that even if they never have to pick up that phone, that if they did, they would get a real person who would help them either over the phone or come out to the house no matter the time of day or night. Hospice provides social workers, chaplains, home health aides for bathing and personal cares, volunteers, and then a lot of, and then also hospice includes the physical therapy, occupational therapy, speech therapy, not really with a rehab focus per se, but with a safety focus to make sure that things are going as well as they can with moving that patient around safely so that caregivers aren't hurting their backs. The speech therapy becomes pretty important. As we know with ALS, the swallow muscles, along with all the other muscles, get weaker, and speech can help determine what diet is safest for that patient to be eating. And then the hospices have a little variability between companies if they provide some of the extra perks like Mayo Hospice does, massage therapy, music therapy, and pet therapy. Hospice also provides the equipment that a person needs. So that's often a hospital bed with maybe an air mattress to help prevent skin breakdown, an over the bed table, some of that respiratory support equipment, commodes, walkers, wheelchairs. Hoyer lifts become important as mobility decreases. So that's a lift to safely move that patient around and not have family again, you know, hurting themselves or the patient. Hospice provides, they pay for the majority of the medications, all of the comfort medications, so that can be a little financial help to the family. Again, there's that 24/7 availability of a nurse to help out. It's important that families do know that the nurse is not, or any of the staff for that matter, is not in the home 24 hours a day. So it really does fall to family to be the caregivers, which can be a lot to ask of a family. Or sometimes these patients need to go reside in a facility where family can visit and maybe support some of the caregiving, but that staff at the facility is really providing that caregiving role. Hospice provides up to 5 days of respite each month. So that's not in a crisis because there's caregiver breakdown, but that's something that's planned. Somebody wants to go deer hunting, just to relieve that family for those 5 days, and I believe it is 5 overnights. And that is done in a facility then with a contracted facility. And then hospice also provides care for the entire family for up to 13 months after a patient's death. There's a bereavement program. Sometimes it's something people need right away, and sometimes there's a significant, holiday or birthday or anniversary that kind of crops up some emotions again, even months down the road, and families know they have somebody they can call for support through that. Who pays for hospice? Hospice is paid for 100% by Medicare and Medicaid, so there is no cost to the family. One thing to know though is hospice does not pay room and board in a facility. So I always tell people, just like we don't pay your mortgage if you're in your home, we don't pay for the room and board in a facility. So that cost does fall to families. Usually it's pretty rare that room and board is covered by insurance. The hospice itself is covered. Most commercial insurances will also provide for hospice care. It's pretty rare we can't find an agency that's contracted with their insurance. And then if people are absolutely unable to have a pay source, I know different hospices do different things with charity care, because really we wouldn't want anybody to go without that benefit. So with ALS, when is it time to consider hospice? Really when there is the decreased functional status, and the goals have really kind of pivoted from not returning to the hospital and clinic, but to allow natural death without mechanical interventions in the absolutely most comfortable and peaceful way possible. Also, when respiratory function is worsening and it is decided not to do the ventilator, the tracheostomy, just to let things be more natural with good medication control. And when there's a decision not to pursue a PEG tube, at some point people just are not able to orally intake what they need. And without a PEG tube or some sort of feeding tube, that does hasten things a bit. Hospice provides really good family and caregiver support. They listen, they provide information, they help families understand what's going on with the disease process, and patients do, obviously, and can kind of help determine, when they're seeing changes in your loved one, and help know how much time might be left. Again, helping with decision making and links to caregiver resources. I think the hospice, especially like chaplains and social workers, they know a lot about support groups and other things that can be of help. So it really is important to consider options ahead of time, so that patients can maintain as much control over their care as possible. And again, when there's a crisis, there's already been kind of a decision what's going to be made at that point. So it just makes things go more smoothly to have hospice on board. The less stress at the time of crisis, and really by patients, thinking very thoughtfully about what they would and wouldn't want, and sharing that information with their families and friends. It really is a gift, so that when the time comes to, maybe not start the ventilator, it's not your family or friends feeling like they're making that decision for you. You as the patient have already told them, and it is just moving forward. So I think the more planning that can be done, absolutely the better. So it is time for questions.
So Kathleen, I'm thinking we can maybe end the recording now, and then we'll have some Q&A.